Hello, may peace be upon you. This is second part of carcinoma stomach stepwise approach. In part 1, we have completed the step 1, we have completed the step 2, and we were talking about investigations. We are going to talk about continuing for investigation, chemotherapy, preparations, then treatment and chemotherapy, surgical treatment. And in light of investigation, we should determine whether the cancer is curable or incurable. Now, cancer is curable if it invades adjacent structures that can be removed safely or involvement of regional lymph nodes, T3 nodal status, up to T3 nodal status. We are going to discuss TNM later on. So therefore, to achieve a cure, it is still curable if the cancer has invaded the adjacent structures, but we can remove that portion of the adjacent structure. It is technically feasible possible, so that we can have a tumor-free edge of that resected or that cut organ. And it also includes the lymph nodes, regional lymph nodes, T3, 10, 11, 12, some with lymph nodes. If they're involved, it is still curable. In incurable, obviously if patient is a hematogenous disease, then it is incurable. The treatment is chemotherapy, and that is palliative chemotherapy. Similarly, if there is involvement of peritoneum away from stomach, fixation to a structure that cannot be removed, and for nodal disease, that is more than 50 regional lymph nodes are enlarged, then it is not curable. So in these cases, if surgery is to be done, then surgery is done to palliate a clinical feature, a symptom due to carcinoma stomach, which could be an obstruction, like gastric outlet obstruction, patient cannot take orally well, or it could be a bleed, which cannot be conservatively managed. Then in such cases, surgery is done, but the aim is to palliate the clinical feature and not to cure the disease. Now that is a separate issue. Okay, by doing that, we may excise the tumor in the stomach also, then that will be called as palliative resection. Incurable, the treatment is neoadjuvant chemotherapy, followed by surgery, followed by chemotherapy. In incurable, treatments, chemotherapy and surgery, which is need-based. And usually surgery is done if patient is fit, because patient has symptoms. So you have to give neoadjuvant chemotherapy, as I was saying, pre-operation, operate. Now in operation, if, as I was talking, it is curable, then we have to do radical gastrectomy. If it's uncurable, if fit, we do palliative gastrectomy to palliate symptoms. And if unfit, minimum surgical procedure is done to palliate something, like if patient cannot take orally, then to provide calories, we might think of doing feeding jejunostomy. That will also decrease the frequency of vomiting, because things won't be going into the abdomen, and so on and so forth. This is an example. And then again, chemotherapy. Now, surgery for distally placed cancer. A point to understand is, it is not essential to do radical total gastrectomy to achieve cure. Important point to understand. If distally placed cancer, one can do right partial, subtotal gastrectomy, provided the left resected margin is 5 cm away from the cancer. For proximally placed cancer, total gastrectomy. For diffuse carcinoma, total gastrectomy. Now once we've understood this thing, now we are going to come, okay, let me tell you in figures also before I come. Now this is normal stomach. This is called as proximal gastrectomy. It's a cancer, even you can do that, but very rare. One can do it. 5 centimeter, if you can achieve. This is distal gastrectomy. At least 5 centimeter is achievable. And this is total gastrectomy, because you see 5 centimeter was not achievable here. Another example, same, if you have done distal gastrectomy, which is distal partial subtotal, then this much stomach will be left behind. This is going to be cancer-free margin, and then you can then make a path so that the food can go further forwards. Classically speaking, there is a difference between the term of partial and subtotal. If you are removing round about 50% of the stomach, it can be termed as partial. But if you are removing more than 50%, then that is called as a subtotal gastrectomy, even up to 80%. What is the difference between radical and partial gastrectomy? Number one, the intent is different. Radical gastrectomy, intent is to cure the disease. In palliative gastrectomy, it is to palliate the clinical problem of vomiting, etc. In resection, it is an en bloc resection, including the tissue of the entire greater omentum and lesser omentum, meeting the criteria of curative resection. Resected stomach margin are cancer-free at least 5 centimeter from the tumor margin. This is radical gastrectomy. En bloc means this thing. You remove the cancer and the adjacent normal things and its lymphatic drainage, including the lymph node, draining lymph nodes, in one piece of tissue, not piecemeal. That is called as en bloc resection. Palliative gastrectomy is to intent is not to cure, to palliate the clinical problem vomiting. In it is sufficient to remove the tumor and reconstruct the gastrointestinal tract without following the strict criteria of resection. Then what is the criteria of curative resection? The resected margin of the stomach, at least 5 centimeter from the margin of the tumor, which are the resected margins, are cancer-free. The involved organ resected edges are tumor-free. There is no hematogenous metastasis. There is no distal peritoneal metastasis. And it is a D2 gastrectomy preferably. Removal of the second tier of lymph node is preferably done. That constitutes a criteria of curative resection. Now, steps of total gastrectomy, you can pause the video and you can read them. But important thing which I think you should know is, which can tell us very clearly like this, whether a person has a registrar or a trainee has actually scrubbed to see a case of a stomach case. Before doing a mobilizing stomach, cauterization is an important step. Number two, the first step would be to divide the stomach distally. After dividing the stomach distally, then you raise the stomach so that the bed is available. The bed is visible to you, where you can flush and divide the vessels from the like left gastric artery, from the hepatic artery, flush vessel rising from it, and you can remove the lymph nodes under vision. I think best is just pause and read it. How is GIT continuity established after resection of stomach? After a total gastrectomy, gastrointestinal continuity is reconstituted utilizing a Roux loop, or Roux loop, or the way you pronounce it. After partial gastrectomy, the proximal part of stomach is available, so gastrointestinal continuity is reconstituted using either Roux loop again or Bilrow-2 Polya type gastrectomy. The stomach is closed from the lesser curve of the stomach near the gastrointestinal junction and then perform an anastomosis of the greater curve with the greater curve of the between the greater curve of the stomach and the jejunum. This is how GIT continuity is established. Now, if you see this thing, this is tumor, this is subtotal gastrectomy has been done, this is proximal stomach, and the gastrointestinal continuity is the stomach is closed from the lesser curve, and this is a Roux loop or Roux loop, which is the elementary loop. That is anastomosed over here. This end is closed, and this part of jejunum is again anastomosed jejunum, which is called as jejunostomy. Same thing in a different diabetic way. So the food is now previously going like this, is going like this. Now it will be very easy to understand if you see this thing. Now this is much better if I show you. One of the important things is reflux, because there is 1 to 1.5 liter secretions of pancreatic juices and other juices in this area. So this can get reflux, like if I anastomose this thing over here, then this thing can get refluxed over here. But if you keep a Roux loop length 50 centimeter from here to here, the chances of reflux are minimal. This is an important thing to consider by constructing Roux loop. So characteristics of Roux loop are: the elementary limb of the Roux loop should be at least 50 centimeter to avoid reflux esophagitis. The blind open end of the Roux loop is closed. Now this is blind open end of the Roux loop. If the whole stomach was divided, it will come over here. Two limbs, elementary limb and the blind open end. The Roux loop may be placed in either anti or colic position. So sometimes what is done is a further anastomosis is also made between jejunum and jejunum, which is jejunum. So now this Roux loop could go anticolic or retrocolic, but in case of gastrectomy, obviously you can place it the way you feel like. Should radiotherapy be given? No. There are several radiosensitive tissues in the region of the gastrointestinal tract which limits the dose of radiotherapy, and the carcinoma stomach is not that radiosensitive. So therefore the role of radiotherapy is not there. Chemotherapy definitely. Neoadjuvant chemotherapy improves the survival. Chemotherapy after surgery improves the survival. Best results are currently obtained using a combination of epirubin, cisplatinum and infusional 5-fluorouracil or an oral analog such as capectabine. The same regime is used as a first line for patients in inoperable diseases. Second line treatment using combinations that include taxotrine is increasingly being used. Chemotherapy for advanced diseases palliative. Neurobiological agents like trastuzumab, those people who have Herceptin, HER2 receptors, then they are also effective. These points we have covered in the previous, except possibly second line, the name of the drugs and neurobiological agents. If HER2 receptor positive gastric cancers, we have to give trastuzumab. This is TNM classification. T1 up to mucosa, T2 muscularis mucosa, T3 involves subserosa. For the T4, it has to perforate the subserosa. May or may not be invading this structure, but usually it invades the distal structure also. N0 no lymph node, N1 1 to 2 regional nodes, 3 to 6, 7 to 15, more than 15. Number of lymph nodes. M0 no metastasis, M1 distant metastasis. If you see the lymphatic drainage of stomach follows the vessels as everywhere in the body. So important vessels are left gastric, which you are seeing, the right gastric, which is not visible. Then this is your right gastric, right gastroduodenal, that is there. This is hepatic, you say this is coming with the left gastric, this is the splenic. Now, what is the difference between a lymph node and lymph node station? Lymph nodes are lymph nodes during the stomach. These lymph nodes, if you see, then around the main vessels, they are grouped together. Maybe 2, 3, 4, 1, 2, whatever it is. So each group is called as a station. This group of lymph nodes make a lymph node station. Now, if you see this diagram, these white spots are lymph node stations. So lymph nodes are on the left gastric artery, on the right gastric artery, lesser curvature 3, greater curvature, then right gastric, right gastroepiploic. If you now divide the stomach, take it up like this, then you can see splenic along the celiac axis. These are the present. Near the porta patis, these are all the tumor stations. Just to give you an idea. More clear. Lymph nodes falling in this area will be station 1, this area station 2, this area station 5, this area station 6, this area is 3, 4, 12, splenic area, artery area, 11. This is how it is. Again, another diagram which is showing the. So when we are talking about a D2 preferably, what we are talking about is in D2 the lymph nodes along left gastric artery, along right gastric artery, right gastric artery, gastroduodenal artery, along this vessel, along gastroepiploic vessel, along splenic artery, they should be removed. Along the celiac axis, they should be removed. If these are removed, then that would be called as D2 gastrectomy, which preferably should be done to achieve a cure. Otherwise, if you have done an en bloc resection, margins are clear, and you remove the lymph nodes may be having tumor, but not all lymph nodes. The lymph nodes which are of the next tier, they are not involved, then that will still constitute a curative resection. Although it is not a complete D2 gastrectomy. Well, thank you very much. I hope this helps you in understanding carcinoma stomach. This is a series of my video tutorials which is a stepwise approach. So on YouTube you're going to find it Shukr education dot, then the name of the disease, like this is carcinoma stomach, then dot, and then stepwise approach. If you want to see further videos which may be coming up next times or so on and so forth, please subscribe to my channel. Have a good day. Thank you very much.